take that step back and think, hold on a minute. Why does my child have to do this in Ontario? Whereas if they're in school in Saskatchewan, Alberta, or British Columbia, which are all different provinces with different types of governments and different levels of intervention, and what's happened to the kids in those provinces, and you'll discover it's like identical. And that should be very reassuring.
Hello, OneSunnyDay.com podcast. Today my guest is Martha Fulford. She is an infectious disease specialist and associate professor at McMaster University. Hello, Martha, and welcome to the program.
Thank you very much.
So the topic today is COVID in kids. And based on your experience, that should be right up your alley. So what's your expertise and coming into this, just so people know?
So I'm an infectious disease specialist at McMaster University. Most of my work is at McMaster Children's Hospital, so I do predominantly pediatric infectious diseases, so I do sometimes see adults. And actually, before I became a physician, I was actually a teacher and have a Bachelor of Education for secondary school teaching. So the topic of education is something near and dear to my heart, and the importance of it for our children. So the topic of COVID and schools clearly is something that, for me, hits both of my areas of training. Number one, my past career as a teacher. Number two, my present career as an infectious diseases specialist.
Well, that's great, because I have noted several times just in the COVID discourse, someone will say something about how this is affecting schools. And because I have little kids, I get like the stories back from the kids themselves. And a lot of the disconnect between what's actually going on and what I think people sort of assume is going on, like the intrusiveness of the various measures, is huge. But here, I'll get back to it in a second. So I put some questions out in the Burlington Dads group to try and get like a feel for the general questions that might be asked. And the overwhelming question that sort of came back is, how concerned should we be that these kids will be exposed to COVID, both on a mortality, hospitalization, but secondly, lots of people raise this idea of this long COVID systemic effects going on for years and years.
So in terms of direct impact of the virus on children, this one's quite easy to answer. It's one of the good news stories of COVID that I feel hasn't really been acknowledged anywhere near as much as it could have been, which is that it is a virus that has a potentially quite devastating effect on seniors and people with certain comorbidities, and is essentially negligible in children and in adolescents. The hospitalization rate for COVID is probably less than it is for influenza, and mortality for children and adolescents is either less or equivalent to influenza. The numbers are a little bit hard to tease out, but certainly if you look at COVID from the very beginning in all of Canada, there are, from the age of 19 and under, we've had 15 deaths described. And it's extremely important to note that in Canada, we don't distinguish hospitalizations or death either with or from COVID. So if somebody is admitted to our hospitals with end-stage cancer and they happen to test positive for COVID, and that person then passes away, that's listed as a COVID death, even though they actually died of cancer. Same, for example, if somebody is in a bad trauma, a car accident, if they happen to test positive, that's listed under one of the COVID mortalities. And this is because, of course, everybody who was admitted to hospital got screened. So just to try to put a bit of context to those pediatric numbers, 15 deaths from or with COVID. We do have a Canadian surveillance program that looks at all pediatric admissions. And when we actually dove down into the actual causes of death, only about a third of the pediatric mortalities were a direct result of COVID. The others, the COVID was incidental. And of the children who did pass away, they had comorbidities. So again, not to say that something bad will never happen, but if you look at the risk of COVID to a child or a teenager compared to other risks that we accept without really any second thought, COVID is no different and rather less than a lot of other risks that we accept. And so and it's challenging because the media has been unrelenting, of course, in hammering us with numbers and with no context. So you might hear about one child hospitalized, but without the denominator, without context, without detail, it becomes scary and overwhelming to try to figure out what that means. So it's not to say a child can't get COVID. They most certainly can get COVID, but the risk of a bad outcome as a result of the virus for a child or a teenager or even a young adult is really negligible. So that's the good news story. This is not the same story as it was in our nursing homes. And actually, adults, for adults, in addition to age, which is unquestionably the biggest single risk factor, is advanced age, is obesity, uncontrolled diabetes, and hypertension, which kind of go together, were clearly significant risk factors for poor outcome if a person got COVID.
I tried to look up by comparison, and the way they did this, the Stats Canada, I couldn't quite make it. But the deaths under, just to compare, the deaths under 17, if you go in the average year, is in like the hundreds, right? So I think that when you're comparing, you just compared like hospitalizations to hospitalizations, right? But I think it's somewhat useful to compare hospitalizations to other things because, as you said, right, there's always a significant risk of dying in a car crash, but nobody stays home because of that risk, right?
Yeah, well, in 2018, 179 children died in car accidents in Canada, if you look up the vehicle mortality data. So just to put it in perspective, I don't have the number of drowning deaths off the top of my head, but certainly there have been more drowning deaths in children than COVID deaths on an annual basis. And yeah, so if you look at, and anybody who wants to look at these numbers, they're available as Stats Canada, Statistics Canada. Actually, if you look it up, you can look up mortality by age group, and you'll find all the top 10 causes of death and all the causes of death and all the different age groups by decade. So people can look at this if they want sort of a sense of what are the risks that we normally deal with versus new risks. I think the dilemma with COVID is that it was new and scary. And to be fair, in March of 2020, when we first had our first lockdown, we didn't know what we were dealing with, and so the unknown does cause a lot of uncertainty and fear. But it was very evident, actually, by May of last year, by May of 2020, that this was a disease that essentially picked off seniors and spared young people. This is not new and breaking news. We've known this for a while.
So with that, because I got a lot of questions, would that also apply to the Delta variant?
Yes. Okay. Yes. So the Delta is more transmissible. So it does seem to be spread more easily. There are no data anywhere that it causes more severe disease in children. So there is a large denominator, but certainly if you look at objective, as opposed to hysterical media reports, if you look at objective numbers of hospitalizations, and particularly when you think of the denominators, it's not causing any more severe disease. In other words, it is, as is with classic COVID, if you want to call it that, very similar in terms of it causing either no or very mild disease in young people.
If we take that block off, what about the idea that it's causing long-term COVID damage? Because that came up and up and again.
Yeah, so this is an interesting question. So there are entities that we call post-infectious syndromes, and they're not new. These are well recognized in infectious diseases. So, for example, there's a condition called Guillain-Barré syndrome, which is sort of an ascending paralysis that people can get after certain viral infections and after certain bacterial infections. And a common bacterial trigger is actually something called Campylobacter, which you can get from undercooked hamburgers. So it's certainly possible that you get a mild diarrheal illness after a poorly cooked hamburger or meat or whatever. And 6 weeks later, a very small proportion of people have this ascending paralysis called Guillain-Barré syndrome. There are other post-infectious syndromes. There's something called ADEM, which is sort of an acute neurological condition. And so these are not new. There are some, as I say, very well recognized, some that are not as well recognized. So I wouldn't be surprised that COVID causes in some people a post-infectious syndrome, in other words, long COVID. The question is, how common is this? And there, again, you can't base it on anecdotes, on on chat on, I'm sorry, but on social media. This is not a way to have medical information. So there have been studies that are looking now at how many children have what would appear to be prolonged post-infectious syndromes after COVID, and they're comparing it to a control group. And this is really important because you need to know what's happening in people who didn't get COVID and who's actually had COVID, and see objectively how many actually have uh, so-called long COVID or post-infectious syndrome. And the studies, there's one out of the UK which looked at children, quite a few, many thousands actually, and it may be in the range of 1% have post-infectious syndromes. Almost all of them resolved at the 8-week mark, and certainly by day 56, which would be, yeah. And so that's very reassuring. And the most common post-infectious things that were described in these kids were headache, fatigue, poor sleep, and in some kids, a loss of taste. And the best study is the one that's published in the Lancet, Child and Adolescent Medicine. And so the objective studies where there's a control group show that, yes, COVID can cause post-infectious syndromes, as is true of all viruses. And fortunately, the numbers seem to be very low and don't last for very long. Again, there will always be the possibility of one child or one exception, one adult. But I guess the question is, do you shut everything down forever because of certain really rare outcomes? Or do you try to sort of take that step back and say, how real is this? How common is it? And then actually do a risk benefit. What are the benefits of, for example, allowing a child to go to school and have all the normal socialization versus the astronomically low risk of a bad outcome from a virus? And what we're seeing is that probably COVID or SARS-CoV-2, the virus, in terms of post-infectious syndromes, probably isn't that different than the post-infectious syndromes we see from other viruses. But we're having the challenge is that it's happening all at once. So you have a huge denominator of people that get COVID all at once, so our wave 3, and then 4 to 6 weeks later, you are going to have a wave of post-infectious syndrome. So it feels like something really common. But if you actually take that step back and think, well, how out of the denominator, out of everybody, how common is this? And you realize it's actually not that common. And that's why the UK study, which had the control group, is so important, because you really have to have a control group to understand how frequent this is and to understand what are the symptoms, how long is it lasting, and how severe is it.
Well, you said one thing there, and then you said, this goes on forever, right? But in the mind of, I think, people who are implementing these things, there's this like always this definitive end date, right? Like from the beginning, it's like we're doing this for 2 weeks, we're doing this for 2 weeks, and I have exactly one level 3 university immunology course and one level 3 genetics course. And when they kept saying 2 weeks to flatten the curve, I would say that's not possible, because you're up the curve, right? And whatever measures you put in that slow the rate of expansion, right? When you take those measures away, it'll go right back to where it was, right? And people would tell me, I would get in endless debates about people. I'm like, no, like they would say you're not an expert. I'd say, no, this is just a mathematical function. We don't have to get into complicated discussions of it. This is just the way the math works. I like made people some spreadsheets that would show you that was true, right? Yet the thing that's hammered in people's minds constantly is when the measures come in, if we do this, the problem will be solved, right? If we bring in masking. So I think the question is, how likely is this set of measures to sort of solve the problem so that we don't even have to worry about that small number of deaths?
COVID's not going away. What happens with pandemic viruses is they become endemic. And so the definition of a pandemic is it's a new pathogen that sort of hits a population with no underlying immunity, and it crosses all sorts of borders. So many countries are involved, as is clear with COVID. I mean, everywhere pretty much in the world has COVID. Endemic are the viruses that are circulating and that we have learned to coexist with. So I don't know how many people realize that every single year there are 4 circulating coronaviruses. So coronaviruses are not new to human beings. So we have 4 regular endemic coronaviruses that hit every year, and they cause the common cold, and people get a degree of immunity. because of repeated exposure. So you might get a mild illness, but it's very uncommon to have severe illness from it. COVID is going to be our fifth circulating coronavirus. The idea that we're going to eradicate it, it's going to disappear, that unfortunately is not going to happen. So what happens with mitigation measures, things like lockdowns, no lockdown makes a virus go away. What it does is it buys you time to get ready. And so pre-COVID, we did have pandemic management plans. Of course, they were all predicated on influenza. But the idea is that you try to protect the vulnerable, you slow transmission where it's occurring, you build surge capacity to deal with what is going to be an influx of patients, and you try to maintain the underlying socioeconomic fabric of society while you're dealing with the pandemic. And we had, of course, a pandemic in 2009, the H1N1 influenza pandemic. If you go back, there was initially some hysteria about Mexican flu or swine flu, and then it got labeled appropriately H1N1. H1N1 hasn't disappeared. It was a pandemic, and then it became endemic, and so now it's one of our regular circulating influenza viruses that we deal with every year. And so the idea with something like COVID or with any new pandemic virus is that we try to deal with the worst of the fallout when we're getting the huge initial waves before we get a degree of population immunity. And then it will become a background endemic virus, probably with the same sort of winter seasonality that the other four coronaviruses have. And so it is, I feel, very poor communication on the part of, government, public health. This thought that somehow is going to make it disappear is not the case. Things like lockdowns and mitigation measures help slow it down, but it slows it down until you've made plans on how you're going to deal with the surge. Unfortunately, one way or the other, you have what's called an exit wave. And so whenever you remove these measures, you will always see an increase in numbers before they stabilize again. And that would be called an exit wave. But hopefully when that happens, you've got measures in place to help cope and help mitigate or at least slow down the degree of harm that a pandemic virus will do.
So what people will now say is, well, how come there's no polio? How come there's no other diseases that have been eradicated by vaccines?
There's actually only one vaccine in the entire world, human vaccine, that's been eradicated, and that's smallpox.
Their point would be here, though, right? Their point would be you don't have people dying of measles here, therefore vaccines work. Why can the same thing not be done to coronavirus?
Vaccines do work, but measles hasn't disappeared from the face of the earth. So measles, like vaccines don't stop you from being exposed to a virus or to a disease. Vaccines stop you from getting sick when you get exposed. We're hoping to eradicate polio. It's taken many, many decades and many, many millions of dollars worldwide. But also eradication of a disease has to be worldwide. So there's certain preconditions to eradicating a disease. One is it really can only affect one reservoir. In other words, it has to be unique to humans. As soon as you have animal reservoirs for a virus, it becomes almost impossible to eradicate, so keep being reintroduced. And that's why smallpox, for example, is a good example for a virus we were able to eradicate. It should have a clear clinical presentation, so it's very easy to identify it, and ideally only infectious once a person is symptomatic. It becomes much more difficult to eradicate something if you've got pre-symptomatic spread or very mildly symptomatic spread. And then, it has to be international, of course. I mean, because pandemics are global; they're not unique to your country or to your little group of people. And so the concept, and then of course you have to have a vaccine that eradicates it. So smallpox truly stopped transmission. With COVID, the vaccines stop severe disease, but they don't fully stop all transmission. So we're not at a stage, we don't have something available to us that is going to make this go away, unfortunately. But what we have available to us is something that has made the severity of it go away, and those are the vaccines that we have. But the idea that we're going to somehow get rid of this, we're going to learn to coexist with this. We're not going to get rid of it. And this is true of pretty much every respiratory virus. As I say, in human history, the only virus that so far we've fully eliminated is smallpox for humans. There's one animal virus that we got rid of called rinderpest.
The basic difference is, right? Number one, there's no magical technological bullet that gets it right. You know what I mean? That will stop. So someone will say, well, why don't we just wait another 6 months, another year for that vaccine to occur? I guess it would be similar to saying what I always say is, it's like, well, we got vaccines against the flu, but we can't manage to kill off the flu, right? Why? And I sort of throw it back on people. I say, well, why do you think that? Then they'll say, well, now we really sort of care, right? This is such a crisis. We'll put whatever time and energy we need to do it, and the technical solution will come.
The thing is that any intervention or any measure that you put in, there needs to be a risk-benefit analysis of what happens and whether it's going to work. And so, for example, the idea of, say, a lockdown, it's pretty obvious if you look around the world that no lockdown has made a virus go away. I mean, look at Australia right now. Over half the country is in complete house arrest with the military, literally with the military walking the streets to keep people in their homes. It's not reported much in our Canadian media, but it's not hard to find reports of what's happening in Australia right now. And Australia was supposedly, the role model for COVID zero, but they're not eradicating it even with the military, roaming the streets to keep people at home. And so this is a really, I think, important measure is what are you willing to do to try to eradicate something like this? Number one, it's no longer causing much harm because the vaccines have, dramatically, well over 90% eradicated a bad outcome. But the costs, when we talk about costs, these are significant. The collateral damage of what our measures have done cannot be underestimated. The economic damage, and people say, oh, it's health versus economy, but economy is health. We know that people's financial well-being is intimately linked to their health. And so the higher up in the socioeconomic level somebody is, the better their health. People need to be able to afford healthcare. They need to be able to afford housing. They need to be able to afford food. They need to be able to afford medicines and dental care and eye care and all of that. And so the longer you keep people out of work and not allow a healthy economy, the worse the impact on their health and well-being. Statistics Canada actually put out a report last year in 2020 looking at excess mortality. And so this is really important because excess mortality are how many extra deaths have occurred because of something like COVID. And certainly in the 70 and 80 plus age group, COVID had excess mortality from what we could see. But in the under 60 age group, the excess mortality was not from COVID. The excess mortality was from collateral damage. And so we've got measures that, while they may have slowed down COVID, ended up killing more people. And so when we talk about putting in any sort of a measure, we really have to look at all the costs and the impact. It has to be, at least for me, a total harm minimization approach and not a COVID harm. Because for young people, COVID essentially doesn't harm them. Whereas we have had devastating impact on the health and well-being of young people. We've got eating disorders have doubled and tripled. In our hospital, we had a tripling of severe suicide attempts in teenagers, and they were more severe. They were real. They were very serious suicide attempts. So they required longer hospitalizations. Children who have not been in school in Ontario have had no access, no physical activity, because in addition to schools being closed, extracurriculars were closed, sports were shut down, they weren't really allowed to be with their friends. And so we've had a marked increase in childhood obesity. Childhood obesity is a poor prognostic issue for their future health and well being. We have had major increases in drug and alcohol abuse and in overdoses. Now, I realize that these are sort of multifactorial, but there have been more overdose deaths in young people than COVID deaths. And I guess in my mind, all deaths count, not just COVID deaths. And so when you're looking at saying, oh, just another 6 months or just another 12 months, that's fair enough. Number one, if it actually works. And I think we would argue that, we have to understand what our endpoint is. But number two, you can't have this conversation isolation of everything else that's going on. We have had a marked increase in other types of infections because of lack of access to care, because of, when we turn all public health energies to trying to control one disease, it means we don't have the bandwidth or the resources, and we're not paying attention to other infectious diseases, to other issues affecting our society. And so it's finding that balance of what as a society you want to achieve. So the people who are saying, but it's just another 6 months, it's not just another 6 months without taking a really honest look at what the cost of that is, of what the cost of what has happened to our population. And I don't find that this is being accounted for. It's extremely easy to count COVID numbers. We've had like 300 COVID cases, we've had 400 COVID cases. But even that has no context. It doesn't tell us how many people are hospitalized. It doesn't tell us what the impact was. It doesn't tell us even where that happened. But what we're not seeing is, oh, we've had this many suicides. Oh, we've had this many overdoses. Oh, we've had this many missed sexually transmitted infections. Oh, this is how many congenital syphilis we've seen in the last year because we've diverted all resources. And so these conversations, again, it's in no way to minimize the impact of COVID. COVID has been devastating. But with the vaccination program having essentially reduced the severity by well over 90%, how much better can you get than that? And is, what's a realistic target? And are you willing to pay the price? And it has to be an honest conversation about what that price is. And in Ontario, I think we have to also understand and look beyond Ontario's borders, because Ontario's lockdowns for Canada were pretty strict. And certainly if you look at children and youth, we unquestionably had the longest school closures anywhere in the entire country. And you could look at a similar province like British Columbia, which did not, in fact, do what Ontario has done, and has almost identical curves and probably slightly lower per capita mortality. And maybe think about, how do you coexist with COVID and move forward without having quite the same devastating impact on the rest of the health and well-being of our people and our society? So it's not a straightforward COVID or no COVID. It's COVID versus every other health impact that we've been dealing with. So I know I work at a children's hospital. COVID's not been what we've seen. What we've seen is the collateral damage. We're not seeing COVID admissions. That's very uncommon. What we're seeing is the collateral damage, and this cannot be minimized. The difficulty is that this isn't what's in the media. It's not what people really want to talk about.
Well, I think additionally, they don't think it's going to happen to them, right? So I ran into a couple times people. This is like, because I asked on social media questions, right, to try and get a sense of what people were asking, and I got back a couple times this thing where they would say, COVID causes impotency, right? And this, I'm telling you, this is real. Multiple people told me this, right? And you can comment whether you've seen any, heard of that from legitimate sources, right? But so this seems like something you can't control, right? Because if it's out there and you go out there and you're going to get sick, I think all of these other baskets of issues that you're describing, the person believes they control it. That person believes that their kid will not commit suicide, that their will somehow smooth over the years of lost study, right? I think that that's why the narrative keeps going, because it's like, oh, the boogeyman is you can't control, but you believe you can control all these other things, right?
It's an interesting thought. I mean, clearly people aren't controlling COVID, because here we are. I think if you looked around the world, you could look at every country in the Western world and look at all the different types of interventions that different countries have put in place: lockdown, no lockdown, mask mandates, no mask mandates, school closures, no school closures. And if you put each country's pandemic curve together on a graph, I think you would have a lot of trouble figuring out which country had which measures put in place. Um, so it's a lot more complicated than I think people appreciate. And the idea that we're going to control this is really no different than thinking we're going to control influenza, quite frankly. But I do feel that part of the problem, though, is how terrified people have become in Ontario. And I say this because this isn't the same in every part of Canada. And so there are some areas where people are truly, truly frightened, and others where there's a bit more of a balanced perspective. And I guess the question is, to what extent do you want to control? I mean, you can't control what other drivers are doing on the road, but you're not scared of driving. You can't really control currents in a river or an ocean, but you'll go in the water. So it is an idea of risk perception, what people are willing to accept. And it's a difficult. I don't have an easy answer for what we've done to our society in terms of terrifying them. And how do you sort of try to get people to look at the numbers and look at the actual risk as opposed to the perceived risk? Because that, I think, is where a lot of the disconnect is. People are absolutely terrified of this thing, and it's been very difficult to try to explain to people, look at the actual numbers. Anybody can look up these numbers. Look at the excess mortality, as in how many extra people died because of this in Canada. Try to actually get people to take that step back. Is challenging. I don't have an easy answer for this, because the way this has been portrayed in the media, and I'm afraid social media, I think, has also exacerbated this, because people get into a rabbit hole of sort of reinforcing perspectives. You do get these echo chambers of beliefs, but really is, how do you get people to take that step back? I don't know. I wish I knew. I am very comfortable with the role of the vaccines in protecting me. I don't feel uncomfortable with other people. I don't mind what they do. But unfortunately, one way or the other, COVID's here to stay.
Well, I'm double vaccinated too, but to your previous point about just sort of other people floating out there, and what I think, there was a person who's wrote a book about the UK, about public health and what they call PSYOPs, psychological operations, right? And one thing came into my newsfeed, and it was about the fact that this was excited influenza researchers, and they were like, what we've learned from COVID is, if you want somebody to do something and you personalize it and you make them think that there's an external death on the way, right, you can get them to do things that they wouldn't do if it was just them. So the attack is never, hey, you're safe. It's like, well, your kid might be safe, but then, grandma might come over, and then grandma's friend might die, right? So what they do is they put you at the bottom of the tree of deaths, and you're like, oh, you caused 64 deaths, 100 deaths, right? So that's like a psychologically powerful thing. And then, if you ask me, the problem is not social media. The problem is, in my opinion, public health communications, because what they did from the start is this: they said it's 2 weeks to flatten the curve, right? All of a sudden, a bunch of know-it-alls like Cliff Clavin at the end of the bar, I'll include myself, go, that's impossible. Right. And then, but when you run into people and tell them that there's no way it can go for 2 weeks. I said, if you're not planning to do it for a year and a half, don't bother doing it tomorrow, was my line. Right. So now there's a tension. So a third party that doesn't know anything about is now listening to two people. Right. This is not like somebody who knows you, where you can slowly explain out all the details. Right. And I have a fraction of knowledge in this thing. Again, 2 university courses, but regularly communications come, and I'm like, unless they've changed everything in immunology in the last 10 years, what is being propagated does not fit anything I've learned or anything I think anybody knows. So you get into an argument. Public health thinks one thing, right? Cliff Clavin at the end of the bar is saying something else, right? There's a tension. Then what happens in 2 weeks, a month, public health is wrong, right? The powers that be have communicated something that now doesn't turn out to be true, right? And so now the problem is, which version of Cliff Clavin are people to believe, right? And that's gone on and on and on, where they said, hey, we're putting masks in. I said, okay, what percentage of infections do you think masks are going to stop? And they'll say, well, all of them. And I'll say, well, that's not, you can throw that out right now, right? And so the point is, in this conflict between the two people, right, you don't get a communication from the, I don't know, we'll call it the public health administrivia, right, that says, hey, we're putting masks in, right? It might do some good. Don't tackle people in the store if they're not wearing a mask, because it's not that important, right? Their communication is, this is really serious and your life's in jeopardy if you don't do it, right? And so that's what the average person takes in is walking around with, right? So I don't think that social media is the problem. I think the government apparatuses have given up their immediate path to sort of reinforceable truth and say, we're not going to say anything that might be even slightly wrong, or give somebody the impression. And if something's out there that's wrong, we'll correct it, right? And therefore, it's just 100 Cliff Clavins and people don't know who to really believe, right?
Yeah, I have to agree. I can't say that the communications have been ideal by any means. And I also think that there has been a lot of, I don't want to call it polarization, but very sort of black and white interpretation of mitigation measures. And, masks are a good example. They probably do help somewhat in really crowded conditions, close contact with poor circulation. Do masks do anything more than outdoors? Probably not. We really have essentially no evidence of outdoor transmission, even in like crowded outdoor scenarios. But here we are with these messages have been given out. And it's also different in every jurisdiction, which has also been disconcerting. So, we have mandates in one jurisdiction and no mandates in other jurisdictions with essentially the same outcomes. But yeah, when we first had the lockdown announced last year, I didn't have a problem with it actually in March of 2020 because we didn't know what we were dealing with. But the very first thing I said when I read that we were closing schools and shutting everything down was, there's no exit strategy. And you need an exit strategy. You can't keep everybody shut down forever, and you can't keep, well, I suppose you could, but you shouldn't keep people terrorized forever either. And so the exit strategy is, what are we aiming to achieve? And so slowing, flattening the curve was never to make a virus go away. It was to slow the rate of transmission enough that the healthcare system could cope. And I think people are forgetting that, or at least misunderstanding that when we locked down again in for our third wave in Ontario and most of Canada, but certainly Ontario, the idea was not to overwhelm hospital capacity. It wasn't to try to make COVID go away. And one thing, of course, that you're supposed to do when you have a pandemic is ensure you have what's called surge capacity, because the numbers of people in hospital and in ICU wasn't actually that high for a population of 14.7 million. I think we topped out at around 900 people in the intensive care unit. And that's and that's essentially with a pre-vaccinated population. It's very important to put that in context. But that's out of 14.7 million people. And so, one of the questions, the things that we're supposed to be doing with any kind of a lockdown or any sort of a phase like this is you get ready for the surge and you create surge capacity. But you're right. The communication or the belief that somehow this was going to make it go away, it is misleading. And I think if you actually listen to or look at some of the public health people, there are people saying, no, we need to learn to coexist. But that's a message that's not being amplified very well.
But at what level though is coexisting? Like, I believe, you correct me if I'm wrong, but the like the Spanish flu is now the flu, right?
Yeah, yeah. Spanish flu never went away. It's just one of our circulating viruses.
But the average person, if I think it's a little bit worse than misleading, because I run into people all the time and I'll say the Spanish flu is now the flu, and they'll say that's impossible because they've gotten the impression human immunity is incapable of defeating these things, because public health had this set. I mean, I'm just don't want to put words in their mouth, but there's this background notion where they sort of created this idea where the vaccine cures you, but you can get it again if you have natural immunity, and really crapped on natural immunity back in the day, right? People I run into all the time still think this. They think if you say, well, I'm going to remove the mitigation in school, right? You're now just going to have infinite COVID in the school forever, and natural immunity will never tap that reaction down, right? Is that living with it? Just saying we're going to put the school back to normal, and we're going to have to figure out other ways to deal with.
I don't actually know why in Canada the concept of natural immunity sort of got dismissed the way it did. Natural immunity most certainly exists. If you look at Europe, for example, and even countries that have vaccine, so-called vaccine passports like France, is proof of vaccination or proof of previous infection that count for providing immunity. So they're actually taking previous infection as a sign of immunity. There are countries that are allowing tourism in. I know Iceland, for example, will take, again, proof of vaccination or proof of previous infection as conferring immunity. We know that if a person's had COVID and you give them one vaccine booster, they mount a massively good response to the booster, which tells us unequivocally that they have immunity already. If we look at rates of readmission to hospital and you compare the people who have never had COVID or never been vaccinated with people who've had COVID, people who've had previous infection clearly have a degree of immunity. The thing with respiratory viruses is that neither the vaccines at this point nor previous infection mean you'll never get reinfected, but what they do give you is the reinfection is significantly, like, way less likely to cause severe disease. And again, remembering that severe disease essentially exclusively occurred in seniors. And again, anybody can look up the numbers from the Public Health Agency of Canada and just look at the distribution of who gets hospitalized, who gets in an ICU, and who dies of COVID. The numbers are very clear. So the probably what would happen with COVID, it would be like the other four circulating coronaviruses. COVID would be number 5, and people would get mild symptoms and it would go away. And so, in fact, exposure does give you immunity. For people who are vulnerable to a viral infection like COVID, particularly if it's somebody in a nursing home, we would prefer them to be vaccinated, because getting infection is much more likely to have an adverse outcome than being vaccinated. So you can have your choice of getting the natural infection or getting the vaccine. Either will result in antibody production, but for some infections, you'd rather that they never get in the first place because they might get really sick. And COVID, there is no doubt that severity of disease is most strongly linked to advancing age. Nobody's going to dispute that at this point. And so children getting COVID will, in fact, give them antibodies. So we know that they're actually very unlikely to get sick in the first place, or at least have any severe disease. And repeated exposures will simply give them more antibodies. And all coronaviruses are seasonal. So I would imagine that this will eventually, become seasonal, as is true of the other 4 circulating coronaviruses. I mean, we'll see how things evolve in the world. But the natural immunity most certainly does exist.
So I had one question about this, which I tell people again for my immunology course. Hopefully I know, not going to embarrass myself, and I know what I'm talking about. I guess actually the two things could be true. I could embarrass myself and to have to know what I'm talking about. So what I always say to people is that because that when you get natural immunity, right, isn't each person going more likely to create antibodies to different part of the viral particle, right? Whereas the mRNA vaccines are just single trick ponies with the spike, right? So The reason why this keeps coming up is they keep sort of saying, what's going on in Texas and here. I keep saying my fear is that in these places that have failed completely to control it, you know what I mean? You've had these huge blowups. I think I read 1/3 of Texas school children have antibodies, right? When they do these tests, they all have a varied immune response to the pathogen, right? But if you vaccinate people, they have the same response. So it strikes me the minute the virus rotates off that can change the spike enough, right? Isn't it easier for it to just escape all the vaccinations at once in a way that's not true if you have natural exposure? Or I just don't know what I'm talking about.
Well, there's certainly people who are hypothesizing this. I would put it to all of us that it's actually too early to know exactly how long immunity is going to last. It might feel like forever we've been dealing with this, but we've really only started vaccinating in December, January, and we only started to vaccinate the general population later than that. So how long it will last, we don't know. At this point in time, we have not seen so-called escape variants from the vaccine. And this includes the Delta. People who are vaccinated is not to say that they will never be exposed, they won't get the Delta, but the risk of severe disease, of hospitalization or death is dramatically reduced. If you look at the Canadian numbers, of the people hospitalized who have been vaccinated, it's only 0.07%. So less than 1% of people are hospitalized if they're fully vaccinated. And so at this point, we don't have any evidence of so-called escape variants. Not to say that, you're always going to get some exceptions, but if you look at the United States, they've got over 160 million people vaccinated with very, very few so-called breakthrough infections. So the denominator is important. In terms of natural infection, this is an interesting question because it has to be studied properly, and it hasn't really been studied as well as it should have been, partly because we're vaccinating everybody anyway. And so the idea would be to actually get a group of people who've had infection and actually track their antibodies and see how long it is. And so there's some early studies starting to come out. But I would say both. We know that both getting COVID and being vaccinated give you good antibody response. How well they will protect long term, we don't know. What seems to be true for both, however, is that once you have antibodies, you are significantly less likely when exposed again to have any bad outcome, even if your outcome was pretty good in the first place. The idea that you're going to get more antibodies to natural infection, may well be true. I'm just going to say at this point, I think it's very early days, despite everybody feeling like it's been forever.
Well, I actually meant different antibodies to different part of the particle.
Yeah, you probably do get a broader range of antibody production when exposed to the whole virus as opposed to just a spike protein.
But listen, we're now playing speculation, but that should mean that if you have a variant on the base, some number of those people stop it dead, and it's difficult to roll through your primary school again, right? With a variant. Obviously could be complete escapes, but that would be the basic theory, right?
The coronaviruses are so far been pretty stable in terms of their conformation. They don't mutate anywhere near as much as say the influenza virus does, but yeah, we'll see how it rolls out.
So what would you say to someone who's and I ran into someone who's like, oh, I'm not going to send my kid to JK this year because they're so concerned about the current state of affairs and they're waiting for a vaccine for kids. And then the question they asked me was, what's the relative, risk? It's hard to say because, you can answer this as you will. But what's the relative risk of exposing kids to the vaccine versus exposing kids to the coronavirus? And they still have this fear of the coronavirus, right?
Yeah, well, and that's the dilemma. It's interesting what people are afraid of. So people are, clearly we have a lot of people very scared of coronavirus, and it doesn't seem to matter how often you say children simply don't get sick. It's exceedingly uncommon. It's just unbelievably uncommon to have a child have a bad outcome from COVID. I personally am more scared of the impact of social isolation, of interrupted education, and actually of the anxiety we're putting in our children. I think in terms of if you're worried about long-term harm to a child, you need to look at sort of the social development, the health and well-being of a child. And The other issue about the whole sort of schooling issue in Ontario is I wish people would look at other parts of Canada. So British Columbia is same country, same society, same sorts of people, same sort of education system, and quite frankly, the same virus. And British Columbia never closed its schools after, from September of 2020 on. They never shut down their schools. They did not have mandatory masking in the schools for most of the year. In February, they introduced masking in the classroom for grade 8 and up. And then in, I think, April, it was for grade 4 and up. They never at no point mandated masking of kindergarten or up to grade 4. They never shut down the schools. They didn't shut down all extracurricular activities. They did let children carry on. And this is all in-person learning. And their pandemic curves are identical or better, but the outcome for their children is far better. And so, the people who are scared, it would be useful maybe to look at, what does that child need for health, for developing, but for social, emotional, mental development, because these are really formative years. We know that grade 3 literacy and numeracy are very strong predictors of the ability to graduate from high school. And so somebody that think that, I'll just keep my child out of school for 2 years, it's not going to be so easy to reintegrate that child. That child's not 2 years older than his or her peers. How do you even get that back? But these milestones of development in a child are they're not infinite. And so to neglect that seems to me, in terms of long-term harm, far more serious, because children need to learn to socialize. They need to learn all those interactions. They need language. They need that social stimulation. They need that part of their brain to develop. And maybe if you're, a parent who can do really good homeschooling, that's fine. If you've got a group of people where that child is learning to play and interact and explore and figure out how to work with the world, then maybe that's okay. But this is not true for most parents. And so the idea that COVID is more dangerous than social isolation is an unusual one. And I think this is where how do you remove that fear that this virus, which is really not dangerous to children, how do you get rid of that? And the good news, of course, is that even for the people who were somehow blaming kids for the virus, which I think was shocking, by the way, no child is responsible for COVID. But the risk of it being transmitted onwards is simply not there anymore, because any adult who wants to be vaccinated is vaccinated. Once you're vaccinated, you're essentially protected against a bad outcome. The other thing that for Ontario schools is we were not seeing transmission in our schools. Despite this narrative of schools being unsafe and all these concerns, daycares were kept open, childcare centers were kept open, schools where we saw the transmission, it wasn't happening. You can look at the British Columbia school data. Schools were not a source of transmission. And this is one of the interesting things about COVID that's different from some of the other respiratory viruses, is that it's not to say a child will never transmit it, but the most important routes of transmission were actually adult to adult. So again, it's a personal choice, obviously, for somebody's child. But, if you think of the definition of health, and this is the World Health Organization definition, that health is a state of physical, social, mental well-being, and it's not the absence of disease. That this is really important in the context of COVID. The health and well-being of children and youth is a heck of a lot more than the absence of COVID. They're not at risk from COVID. But the harms that depriving them of socialization, of education, of play, of sports, of all of those things that allow a child to become a functioning adult, that's lifelong harm.
Well, but the people who this is what I find when I run into because I wrote a thing to the trustees before the first school thing, and I basically said, here's what I want. If you're going to put these measures in, I want a table of what whatever metric you want to take, what community transmission means that these measures come in, and then what levels of community transmission means these measures come out. Because otherwise you will invent a bunch of measures and you won't even know why, and it'll be so tough to dig them out, right? Didn't get anywhere with that. I also wanted outdoor classrooms just because I thought it would be cool, and if they want to have the kids outside more, it was great for me. Didn't get that either. But the thing with the kids is, and anybody who's listening, this is a side thing. People keep saying, "Oh, they're having the mask. The mask is no big deal." Like the same school environment is going on, just everyone's got a mask. But the problem is the actual teachers who are running these, they probably know nothing about whatever, right? So many teachers think that the masks are equally to like a gun, like to have the kids with a loaded gun, right? So some of the teachers are super animated about the kid's mask, and they think if the kid has the mask off for a second, except for lunch, they can't get COVID at lunch, remember. But if they have the mask off any time out of lunch or any time of these things, the child's at risk of death. That's how they're reacting, right? So they're putting that amount of stuff onto the kids, right? Then my kids, I'm not freaked out at all. So they're like, you're overreacting. So you have this complete dichotomy in the classroom, and the teacher's like spending a massive amount of time like policing this and trying to keep the kids apart, except at lunch. Lunch, they can take their masks off. But the stress, and for just as an example, at my kids' school, what some of the kids have taken to do is actually drinking water through their masks. Because I'm not kidding, because as she says, they think if they take their masks off, quote unquote, they will die. That's from an 8-year-old kid, right? So I don't think the parents of that kid think they're doing that kid a disservice. I think what they think they're doing is saving that kid's life, right? Because they've seen an ad that says, you could, they've heard an ad with the heartbeat, you could get COVID, and then somebody could get COVID, and you could always take a bad bounce and die, right? So these parents, if you ask me, because one of the things, I don't think they mandated masks on the kindergarten kids, right? But there's about to be a parade of, if you ask me, parents that are going to bombard the trustees. My kid in kindergarten's unsafe. I want those masks. I want those masks. So what would you say to the poor trustees that are going to get bombarded with parents convinced that you're now putting their child in jeopardy?
Well, public health decisions should actually not be made by parents or by school boards, quite frankly. Public health decisions should be made by public health. And what's fascinating about COVID is that public health decisions, of course, vary dramatically jurisdiction by jurisdiction. If you look at the recommendations from the pediatric experts, and you can look at any of the sick kids, the Hospital for Sick Kids documents that were endorsed by every pediatric hospital in the province, and also most recently by the Ontario Science Table, we don't actually recommend masking of young children. Nobody does in any of those documents. The most recent one has a red, yellow, green system in place so that for low epidemic, so when community cases or when things are more or less under control, there are no mandatory masks anywhere, and then you can scale up or scale down depending on what's happening in the community. And the other important thing about the document is that it notes that what's going on in the community should be predicated on severe disease and hospitalizations and not just case counts, because of course, case counts are going to become increasingly irrelevant with vaccination, because if we've completely decoupled case counts from severity, it really doesn't matter if you have a lot of cases in the community if it doesn't lead to any bad outcome. And so there is going to be a complete decoupling of cases with severity. And I guess it would be nice if these poor parents who are so terrified, again, looked outside of the borders of Ontario to realize that this universal masking of children in schools, it was not, in fact, universal. It was unique to Ontario. Across Canada. I mean, you can look at the other school boards across Canada, and again, anybody can look up this data, but this was not a universal implementation everywhere. And, most of the province-wide, in general, the high crowded areas, so hallways, buses, and stuff like that, they were recommended, and depending again on the province, mandated. But wearing them inside the classroom was in fact not universal. And certainly for younger children, most definitely not universal. And so, again, I think, if you're worried about your child, look at British Columbia. If you're in British Columbia, no child before grade 4 was masked. And guess what? their kids weren't dying.
Well, I think that so what they sold was this precautionary principle, right? They said, well, it might not, it's probably not going to hurt anything. It might help, quote unquote, precautionary principle. But see, so because I was working at a letter, there's lots of writings where people have written things and they'll say, for example, just the facial expression in a JK kid is very important for development because the kids can lie, but they can't lie with their facial expression. So it allows the kids to link up someone who's lying with their words with a facial expression that makes them believe that person's not lying, right? And so what I said is, so this is real science. I'm not making this up. There's a potential harm now, right? You can't show me a benefit. So I go, well, why does the precautionary principle not reverse on you now? You can't show me a benefit of the vaccine because the kids aren't going to be hurt, right? But there's a potential real serious negative event with the fact that you've screwed their development up for two and a half years now, potentially, right? Because once this digs into school year, I mean, I was really apoplectic when they did the outside masks. And I was like, what are you, this is crazy. And they still have, I was in a public park and they had a camp and they had 40 kids, probably 10, all in masks, 30 degrees, by the way. And I was like, I know it. I'm like, not one of these kids is talking. Like none of them. They just weren't talking. They were like standing around. And I'm like, this doesn't seem normal to me. So I think it's damaging, right? I think that you can't tell, you don't get grade 1 back. You don't get JK back. But I think that the average person is bombarded by messages like, well, this actually, I wanted to, the other thing is, for example, we just received a school board message. Like this is a school board message from public health for Halton region. Okay. And it uses language like it says the kids are quote unquote unprotected. Right. Like that's the language in the document. Right. And so if you keep using language like unprotected, right, then people are going to be like, well, I guess, I think the problem keeps coming in with these words like safe. They say something safe, and then the definition of safe keeps moving around, right? In that the very, very low chance of negative outcome from the vaccine is considered safe. But even if you use the same percentage chance with COVID, it's not considered safe, right? So the statistics are all moving around inconsistently. So if I understand your take home message, is that you cannot see the hospital is not full of children either with COVID or long COVID, even with Delta.
Not at all.
You don't expect to see that. And because you don't expect to see that, the measures in the schools are not helping anybody.
No, at this point, no. It's unfortunate that they didn't. If I sort of anybody had sort of taken, I think that the Ontario Science Table and Sick Kids document with the green, yellow, red, scale up, scale down would have been a really good system because it's flexible. And at some point we have to figure out this is as good as it's going to get. The whole point of the vaccine campaign wasn't to make COVID go away. It was to make severe disease and hospitalizations, death go away so that we weren't overwhelmed in our hospitals. We've actually accomplished that already in Ontario. It has never been children that have been admitted with COVID. We have never been overwhelmed with pediatric cases, either COVID, long COVID, or post-COVID inflammatory syndromes, the so-called MIS-C. There are some cases, and they will continue to be some cases. There are some cases of post-infectious syndromes from pretty much every virus I've ever encountered. But this message of unprotected and safe is very unfortunate. This narrative that schools were intrinsically unsafe is one that's been very difficult to fight in Ontario. And I can't stress enough that this is unique to Ontario. This is not the messaging that you're going to find everywhere else. If you go to Saskatchewan, Manitoba, Alberta, British Columbia, schools are back to normal with no some measures for certain crowded conditions, maybe certain cohorts, but most of the mitigation measures are gone. They're saying, no, it's over. With adults protected, we believe that we have accomplished what we set out to do. And both Alberta and Saskatchewan are essentially saying we're going back to normal public health measures now. We're no longer doing extra COVID measures. And so I think it's really important for Ontario parents to look around and maybe look at what's happening in other jurisdictions and sort of take that step back and think, hold on a minute. Why does my child have to do this in Ontario? Whereas if they're in school in Saskatchewan, Alberta, or British Columbia, which are all different provinces with different types of governments and different levels of intervention, and what's happened to the kids in those provinces, and you'll discover it's like identical. And that should be very reassuring. The fact that no child in a school in British Columbia under the age of grade 4 was required to wear a mask is an important piece of information, because those schools did not have a lot of transmission. There was not, the sky did not fall. The hospitals were not full of pediatric cases. Then, in fact, another important thing about that, if you can think about it, is that they didn't even see much transmission to teachers in these classrooms with where there were no masks being used. There was a study that got put out from Vancouver that actually looked at serology, so looked at antibody levels. So they weren't even depending on a test. They were looking at actual, has this person been exposed to COVID? And they looked at over the whole period up to and including the Delta. And the teachers' antibody levels were no higher than the antibody levels of anybody else in the community, so that they were not, in fact, seeing that much transmission, and teachers were not at particular risk. So all of these pieces of information, I mean, we're a year and almost a year and a half into this. We should be able to learn from other jurisdictions and not just, be in constant panic mode. So the issue with schools is challenging, because Ontario has the longest lockdowns and the most restrictive measures in the schools. And the impact on our children and their future is going to be profound. It's going to be utterly profound. And unfortunately, some of this harm isn't going to be seen for years and years. But for the parents who are worried, it would be useful, I think, to take that step back and think, okay, let's just look at children everywhere else in the world. Look at children in Northern Europe. Look at children in Sweden, in Norway, in Finland. Look at children in the United Kingdom, in Scotland, in Iceland. Look at children and schools in Switzerland, in every jurisdiction, and see, has any jurisdiction had a problem with kids and COVID? And the answer is no. Has any jurisdiction had a problem with school transmission? And the answer is no. But have we seen collateral damage from school closures? And the answer is yes. And so this far into this, we should be able to learn, I think, from what's worked and what hasn't worked. One of the things I think about masks that's interesting, again, I mean, I think there's a role for them in certain environments, but I don't know if anybody knows that there has not a single study on whether masks work in young children. And I say this because, of course, a mask works if it's worn properly, if it's under controlled conditions, and a wet cloth mask that a small child has been chewing on for a while is of no use at all. If somebody's drinking through a mask and that mask gets wet, that is rendered utterly useless. And so these are all important things, and it's hard. Shades of gray are hard to discuss, and so the nuances are hard to discuss in terms of what works and what doesn't work. But over a year into this, what we know is children are not dying of COVID. This is something that should be reassuring, and it should have been one of the good news stories of the pandemic that was being trumpeted. We should have been celebrating this. We should be celebrating the fact that the vaccines have essentially declawed and defanged this virus, so that the threat to our seniors and to vulnerable adults is essentially eliminated. We are in a position which is dramatically different and so much better than we were a year ago, and yet somehow we haven't been able to figure this out psychologically yet.
Well, it's not even the masks, right? Because it would be like doing a study of people wearing masks to keep themselves safe, except at lunch. Like, the kids in Ontario are sitting in masks for an hour and a half, and then they say, "Oh, it's lunchtime. Everybody take your mask off." right? The person is like X feet away while you eat lunch, which they're allowed to talk. They changed this. Now they can talk, at least in Toronto, and they could always talk here. If your teacher allows it, though, that's the thing. You can get somebody who's, really animated, right? And then they put the mask back on, and then they do their, go outside or whatever, and then they take the mask off. So you have definitionally X number of hour, or, an hour of exposure eating lunch around the other kids, right? So it's somebody's going to say, well, the inoculum dose or whatever is less because they got whatever, right? Which may be a theory, but you're now sort of corner casing a theory to corner case a theory to find some advantage. And to me, it's not directly that the masks are screwing the kids up at all age. It's that it is that, for example, they used to have the desks in a grade 1 classroom or grade 2 classroom in clusters of 4, at least my school, right? And then they're like, oh no, we can't do that anymore. They're in like a weird grid, right? Because the public health people said all the classes have to be in grids for some reason. So everybody's got this grid now, right? There's no longer this little group where and all of the things that they used to be doing, like emphasizing group work and emphasizing, this kind of thing used to be their bag, right? Is all gotten scraped away. So it's not the masking and the distancing per se. There's a follow-on effect where the poor teacher tries to implement these rules on the kids, right? And we're all, obsessed with the masks and the distancing, and then one kid's super animated, and therefore we're not just worried about having a good time. Like the good time element works. Like my kid was in love with grade 1, in love with school, right? And now she's like, it sucks because all the fun stuff has just been carved out, right? And so that's where I think the harm is.
No, I think the harm is profound, and I think, and again, I think that we have elevated the risk of COVID to a point where it's almost irrational for children. The risk to teachers is gone. Any teacher who's concerned, who is high risk, can be vaccinated. The children were never at risk from COVID. The harm to children is the collateral damage. And it's also, I cannot emphasize enough that all of this stuff that's being described for Ontario is kind of unique to Ontario. This is not being reproduced everywhere in Canada, and most certainly not in the world. And there are many, many jurisdictions that said the education of our children is the single most important thing that we have to focus in on. This is the future. And we're not compromising it. Schools were never shut down. They didn't have all these peculiar measures in place. So this isn't a universal thing that's happened. This is it's something that has happened in Ontario. And it should be reassessed. We are in a very different position. And I'm not sure. I'm not seeing a lot of optimism, quite frankly, in the attitude in Ontario in our schools. But I look around Canada, and I think this is, unfortunate, because certainly there are many examples where schools are back to normal in our country. It's just not in Ontario. And I would emphasize, I think we could learn from other jurisdictions, that we already know that schools were safe. We already know that the teachers were not getting COVID from the students. These studies are unequivocal. We know that adults are protected now if they've chosen to be vaccinated, so that the reason or the rationale for these ongoing restrictions becomes less and less clear. And at some point, we need to talk about the exit strategy. We need to talk about what the future is. And maybe for some people, the future will be like this forever. I mean, this isn't obviously a decision I can make alone. But I think as a society, we do need to think about what is it we're trying to gain, what is it we're trying to achieve, what is it we'd like to be. And this is an honest one. I think we could learn, as I say, I keep saying we could learn a lot from what's happened and worked in other countries. There's a lot to learn from Sweden, Norway, and Finland. They've never had mandatory masks ever in any of those jurisdictions in schools. And so these are all sort of conversations to have as to, we don't have to reinvent the wheel in Ontario. We could actually figure out that we didn't need to, or at this point in particular, we no longer need to do these things. And as I say, anybody can look at it. It's freely available. The Ontario Science Table and Hospital for Sick Children document that got published a few weeks ago very clearly outlines the harms that have happened to our children and strategies for mitigation measures depending on community transmission. And this is allowing for the withdrawal of all these measures. And this is something we need to start to think about. COVID's not going away.
Well, I mean, minus yourself, which thanks for my, I've seen your TV appearances and stuff, and you're very generous of your time getting this message out. But I do think there's a problem where these are obviously politically difficult questions. Somebody puts out a thing, the government does something different, right? If they were under relentless pressure, there is not an uprising of average medical professional, right, for whatever reason, pounding the crap out of the government by spending half an hour going to their local paper and saying, I'll give you 15 minutes of my time, right? What's going on in this school is, unacceptable. What's going on in this school? The silence of the average person who must think this and sort of writes their thing, average infectious disease doctor is not an average person, right? But it does strike me there's awful lot of silence from people who must know exactly what you're saying, right? And for some reason are kind of like, well, I'll stay out of it. And that gives the impression to people that this is reasonable, right? If there was an article a second, and I have gotten into discussions with many people before, and I get to this point, and they'll say to me, well, if what you were saying is true, Greg, there would be an uprising. There'd be letters with 500 doctor signatures, 500 pediatricians rolling in.
There were such letters. They just didn't get amplified.
Right. Okay, well, fair enough.
They were. I mean, in April, before it didn't reopen the schools, there were letters endorsed by every single pediatric organization in the province. There are letters signed by that many physicians. They just don't get amplified. The media doesn't report on them. They don't get reproduced.
Right.
We've been doing this for a long time. So actually, there have been attempts to have our voices heard, and for whatever reason, it's not the message people want to hear.
Because, well, and I did know, I knew Jay Bhattacharya before he got going on. I knew him way before he got going on this Great Barrington declaration, and I watched him in a JAMA debate with this other guy. And even though I agree with, I understand what Jay's saying, right? He was getting destroyed in the debate not destroyed, but he couldn't get his point across because the other person just kept repeating like a mantra, these measures will save some number of lives, even if it's one life. This lockdown will save lives. This lockdown will save lives. And he kept saying, yeah, but if you close a gym, people are, now more overweight and they die later, right? But they could just sit back to, it's like, this will save lives today, and then some other thing will be invented to fix all these things tomorrow, right? Whereas, I had a conversation with on the podcast with the school board trustee that was then running for whatever, and she was sort of talking about education. I said, well, it's a $5-6 billion system, right? We're never going to reproduce grade 1 again, right? Like you can't pretend there's a $50 billion education system coming, right? To catch every kid that's fallen through the cracks and to sit them down and sort of say, you don't need to be concerned about that. But I can see it leaking to influenza for sure. You already get this article. Oh, look, we can take all the great things we've learned about COVID and apply it to influenza. And these kinds of things. So there is a massive, I think, disconnect, which is why I wanted to have you on today, because to me, there is no cost benefit analysis whatsoever, because when the person says, hey, we're doing masks, we can come up with a couple potential negatives, which we can throw up papers that say, here's the importance of kids seeing other kids' faces in development. In kindergarten, when they have a sheet that shows all the kids' expression of faces and goes, this is sad, this is crying, right? There must be some reason for that. See what I mean? So you can demonstrate that this is true, but I find when you go to people and they say, people are really in love with the masks work, I say, okay, how many percent of cases do you think that they're preventing, right? And they can seemingly never answer that question. And on the point of masks, when they had masks in, my fear with masks was, I said, it's not that you're not going to get some benefit from them. I bet you'll get some benefit if only the benefit is that they're a pain in the ass and people don't want to talk to each other in the hallway, I'm sure you'll get some benefit from them, right? The problem is if you make somebody think it's 100%, right? They now make errors. And I've seen this a couple times where I've been in conversations with somebody and they'll say, well, I'm visiting so-and-so in the old age home and we're giving somebody else a ride for an hour and a half in a car. Don't worry, we all wore our masks. And I'm like, you're in an hour and a half in a car? Why did you think that was going to work, right? So I think there's a danger. I think part of what you've got now is a danger in you've put ideas in people's heads that aren't really true, but they're now running on them because they're like, okay, I feel safe. I have my mask. I feel safe. I'm keeping distance. I'm doing all these things. Why wouldn't that apply to my kid? Why doesn't that apply to the whole classroom, right? I think that's scaring people is easy. Unscaring them is very difficult.
Yeah. I don't have an easy answer to that. I mean, the masks have become a very emotional touch point. It's both emotional as political. It's, there are a lot of issues around masks. Certainly masks when worn, by trained healthcare personnel in controlled settings, clearly do make a difference. I think they're a very important thing we do for personal protection. Whether masks as worn by the general public have an impact on the course of a pandemic is another question. It's a very politically sensitive one because nobody's really allowed to question this anymore. But again, I think, people could start to look at jurisdictions where masks have been put in place and masks haven't and start to ask and try to figure out what's worked. The difficulty, of course, with what are called non-pharmaceutical interventions like, public masking is it's a very heterogeneous thing. I mean, we don't really know what masks people are using, under what circumstances, and nobody just masks. Lots of other measures get put in at the same time. But one thing that is very clear is that masks are not 100%. They were never meant to be 100%. There's a thing called a hierarchy of controls. It's sort of a triangle of the most effective to the least effective interventions in terms of preventing disease transmission. And obviously eliminating the disease is number one. If you can get rid of it, then you've solved the problem. And so this is where the role of vaccines is really important, is that it may not have eliminated it from the world, but it certainly, to a large extent, eliminated severe outcomes. You can go through various structural things, but the least effective of all of the measures in the hierarchy of controls is actually personal protective equipment like masking. And yet it's been elevated to the most effective. And so the role of a mask is absolutely not 100%. I don't think there are very many people who would claim it was 100%. There are jurisdictions that even mandated wearing N95s, and this was in Bavaria and Germany, for example. And even if you look at the use of the N95 masking that was required by everybody in the one region compared to the rest of Germany, you don't really see any difference in the pandemic curves. And so it's a very complicated, nuanced conversation. And as I say, the role for the masks almost certainly was and remains in really crowded conditions with a lot of very close contact and poor ventilation. The role of masks in other settings is something that we've taken it on. To what extent it changes the course of a pandemic, I would say is an open question. And certainly, but certainly the belief that it's a 100% barrier, no. I don't think anybody has ever, certainly no medical professional would claim that it's a 100% barrier.
Oh, one health guy was just at a press conference. I won't say where, but he just said, the reporters asked him, he said, "Oh no, we have cases of mass to mass transmission, where like somebody was sitting beside
Of mask to
yeah, there's a person sitting with the mask the whole time, and there's another person 2 feet away sitting with the mask the whole time." And he just said that they had cases of that. He just said they had a case of that, right? And my point is not if it's right or not. My point is he got killed. That was it was like irresponsible for him to say such a thing. Was the point that I was making. Came from this press conference, right? So it's kind of an incredible political comment. It's kind of a really amazing political climate all of a sudden, right? Where you can't, like people say defensively, "I'm double vaccinated," which I am double vaccinated, right? And so people have to say that, because the idea is if you don't say that, you're some sort whatever follows can't be taken seriously, by a credible person. And I from the for most of these things from the beginning would all I'm ever all I was ever saying is no, everything's going to have some percentage of effectiveness, right? And what seems to happen with every one of these measures, it comes out, the masks are going to make either make it go away or do a significant difference. They put it in, it gets lodged. Then we're doing the social distancing, it gets lodged. We've got arrows in the supermarket now, thanks for that. That gets lodged, and then some amount of time later, it's like, well, it didn't work as well as we thought. Maybe, who knows, right? But it might be helping a little. And I'm like, you had a year and a half to come up with something. Like, if it really made a massive, definitive difference, you could. And I said before, I said the greatest thing is the United States that did every experiment for us, right? And then you can compare the states to us, and what you did. And I with you, I'm no expert, but I look at the curves because I was arguing it, and I'm like, it doesn't seem to make that much a difference. I have this great chart because I was arguing with the Burlington people when they did the original masks, and I have this graph, and it's like Cuba and Florida, or no, sorry, Cuba and California. I have like a little red arrow for mask mandate, and it's like before the curve takes off at all, there's this like little red arrow, and some of the counselors emailed me back, and they're like, yeah, it seems that it doesn't. It's not like you have this like thing going up and they do masking distancing. It just crashes down. So I'm with you. Is there anything you'd like to add that you think people need to know about this?
I think probably it's really just this sort of recognition that the pandemic viruses don't disappear; they become endemic. They become one of our normal circulating viruses, and this isn't necessarily a bad thing. It means that between vaccination and natural immunity, we have reached a steady state where it becomes one of our normal seasonal viruses, and that this is the where we're heading for is learning how to coexist, so that the measures that were put in place at the beginning to try to slow down the transmission aren't meant to be permanent. They will become optional. I think there are some people who are very, very nervous and will continue to wear masks, and that's okay. But I think there are also an equal number of people who are going to be very comfortable saying, I'm happy that this thing is under control. It's now an endemic virus, and they will no longer be using any of these mitigation measures, and that's also okay. But we are heading into a phase of moving from pandemic to endemic, and to really this being one of our viruses that we coexist with. And this, I think, is something that's where we're headed, actually. And I don't know when Ontario will get there. But certainly, if you look around our country, there are other jurisdictions that are already much further along the path of accepting that this is now one of our endemic viruses.
So a couple people said to me they want to wait for the vaccine for kids.
I think you have to understand what the vaccines is. It doesn't make the virus go away. It's just pretty clear. What the vaccines do is they prevent severe illness. So if a child doesn't get severe illness in the first place, the risk benefit for the child is very different. The reason for vaccinating young people isn't actually so much that it protects them, but because the least amount of virus circulating in the community, the better off we all are. But the risk benefit for somebody like me or for an older adult is it clearly protects me from the possibility of getting severe disease because I'm at a higher age bracket. The risk benefit conversation with young people is very different. It's not so much that their particular health is at risk, but overall it is a desirable outcome for us to have a very small amount of circulating virus. There are many countries and jurisdictions that aren't actually vaccinating youth at all. So again, we have to sort of look around and realize that this isn't a universal attitude that we have to vaccinate our youth. There are other jurisdictions saying they don't need it, that the risk to children is negligible, so they don't need to be vaccinated.
And there is some real cases of, I thought, muscular heart inflammation.
It's myocarditis, yeah, and pericarditis, yeah.
But that's real, right? Like,
yeah, oh yeah, it's very real. So we're seeing it about 20% after the first dose, 80% after the second dose. And so you're seeing both myocarditis, which is inflammation of the heart muscle, and pericarditis, which is inflammation of the lining of the heart muscle of the heart. So far, the cases have been self-limited in that we certainly have had hospitalizations from this. Uh, I haven't seen any bad outcomes at this point. I mean, well, they've been hospitalized, but they all seem to respond well to non-steroidal antifungal. No, it's a very real adverse effect. Make no mistake. Um, it's rare. I don't think we know exactly how rare at this point. It seems to be around 1 in 50,000. It might be higher for teenage boys. It seems to affect young men more than anybody else. But we're accumulating the data. I mean, we're the thing is that only the United States and Canada at this point are pretty much mass vaccinating teenagers. It's being done in a few other jurisdictions now, and so the data is being collected. So it's very real. It's rare. So I'm not going to deny that there are potential adverse effects. My overall sense is that these are still very safe vaccines, and that the benefit likely outweighs the risk. The benefit unquestionably outweighs the risk for older people, and for younger people, I have no particular reservations at all about vaccinating them, but I would just be very cognizant that the risk-benefit conversation for vaccinating young people is different, because their risk from COVID is not the same as an older person. So the risk-benefit conversation there becomes one of a societal benefit of minimizing the amount of circulating virus in our community. So it is a different conversation. But in terms of do children, they, this is a conversation. Is this a vaccine preventable disease, or is it a childhood infection that we accept? I mean, we accept all other respiratory virus infections pretty much. So my personal thing, I would never have deprived a child of school because of this. To me, the risk of COVID for a child is negligible.
Right. And then, so the other question is, with all these interventions or whatever, once you get these kids back in school and you eventually remove these mitigations, right? Or is there not going to be some massive swamp of RSA, flu, and all these things?
RSE. So there's this concept called sort of viral inhibition, where we're COVID seems to sort of gotten rid of other viruses. There are some people who are saying that we're not seeing influenza because of masking and all that, but this is not true at all. Influenza has disappeared from everywhere in the entire world, regardless of what mitigation measures may or may not have been put in place. So Florida and Texas, South Dakota, which never really shut down, they had no flu either. So it's not that it had nothing to do with masking. Influenza around the world has disappeared, and we've got COVID instead. And so it's not because we're masking that influenza's gone away. It's just gone away. RSV is one of our normal childhood viruses. It's potentially actually very severe in the very young. We every year we have babies, usually under the age of 12 months, hospitalized with RSV. It doesn't cause severe disease in older kids. These would be very uncommon. Are we going to see a resurgence of these? We may well. They're already seeing that in other jurisdictions, particularly RSV. These viruses will come back, but I think they'll come back regardless of what we're doing in our schools. We're seeing it in pretty much, a lot of jurisdictions are starting to see this already. And the thing is, you have to balance. We can't be germ-free. We actually need to have ongoing exposure to pathogens in order to have a proper buildup of an immune system. And so you want to sort of you don't want to risk people getting severe disease, but we can't live in bubbles. We need to have a mature and developing immune system that will last us a lifetime in terms of protecting us against exposure. So are we going to see a resurgence of RSV and adenovirus and corona? I suspect we will see them.
And nobody knows really why those things are suppressed.
It's complicated, but it's probably to do with this whole sort of viral inhibition thing, where one virus is almost like one virus is occupying the real estate, other viruses aren't there. I don't think we really know, honestly, but it's pretty simplistic to say it's because of these mitigation measures. It's also kind of weird if you're saying that all these mitigation measures got rid of influenza, but COVID's alive and well, thank you very much. So either they work or they don't work to get rid of viruses. And so and most important with things like all the other viruses is that they were pretty much suppressed everywhere around the entire world, regardless of what was being done. And so I don't think it had anything to do with is a far more complicated story that I don't think we fully understand. But are we going to see them again? Yeah, I think we will.
Well, I read this great right off the cuff. This flu guy put out this paper. It's like a 20-page paper, and I read through it. And like one of his opening lines is, "Oh, you're going to figure out, what percentage of COVID cases come from like contact or aeration or droplets." He's like, "Good luck to you. We've been trying to figure that out for 20 years in the flu, and nobody has an idea. So good luck." And then he's basically it's funny as this thing becomes truer. He's like, it'll go endemic and it's run by humidity, and he has this humidity curve, the seasonal humidity curve, and he's like, this is what the flu does. He's like, this is what this will do. And you can basically, summary is, you can come to that conclusion in a week, year, or 10 years, but eventually you'll just arrive to this unescapable influenza up and down curve, and you can make some vaccination for people who are at risk in the old, and then they're going to be like, well, we did what we could. Okay, well so what's next?
What's next? Excellent question. I mean, I think what's next is a slow transition to our exit strategy and figuring out that, sorry, but COVID's here to stay. And how do we learn to coexist? I mean, honestly, I think what's next is slowly returning to normal, as is already happening in quite a few countries. And what's allowing that to happen, honestly, is the vaccination of adults. I think we're seeing it in the United Kingdom, we're seeing it in Israel, we're seeing it in parts of the US, we're seeing it in parts of Canada, we're seeing it in other jurisdictions in Europe. What's next is accepting that this is what we can do. We've protected the vulnerable, and now we need to resume a normal life again, with COVID as part of our normal life now.
Aren't you sort of smart to not overprotect the kids when you have a circulating variant that you know is not going to create a massive amount of disease, rather than just, I don't know, almost waiting till it appears and then being like, it's now real? Or is that just...
COVID is not what's brought our kids to hospital. That's not what we're seeing. We're seeing the collateral damage. Delta or no Delta, what we're seeing in our hospitals has not been COVID directly. So I guess for me, it was never the children that worried me. It was the seniors and the vulnerable adults that worried me.
Right. So your summary is the measures do a massive amount of harm, right? Which we can see. We can see the kids in the hospital suffering from the harm. So that's real, right? We don't see a bunch of kids with COVID or long COVID, right? So they're not being harmed. We don't see a massive number of adults we see with COVID or long COVID that it would be in the ratio that we would expect, somewhat normal for them to get a normal flu, or everybody takes a bad bounce and ends up in the hospital like on some time, right? And so because of that, we now have the adults protected, the kids were pre-protected, there's no one we're protecting anymore, and it's time to go back to normal. Is that the basic summary?
Yeah. The people that probably still need protection is that we do have areas of the adult population that are unvaccinated. And these are not people who are anti-vaxxers. I mean, the reason for people not accessing healthcare are, again, very complicated, but these are marginalized populations. They may have already had very poor experiences with the healthcare system. These are people who maybe are already borderline in our society in terms of being able to actually understand or get somewhere. There may be language barriers, education barriers. So I think there are pockets within our communities where we still need to reach people, and not because these are people who are intrinsically against it, but these are people who have had very poor experiences all along. And so there are still some vulnerable adults that we need to have outreach for, but we're well on the way. I mean, our numbers in Ontario for vaccination rates are really high. So, I mean, will cases go up? Yes. Will hospitalizations go up? Not really, nowhere near to the same extent they did before. So this is steady state.
You missed a case, though. I think there's a real person who, for example, you said the vaccines are safe and effective. The vaccines are safe and effective, right? You had some very bad AstraZeneca reactions that seemed to be real. Even in the midst of that, you still had this messaging, it's safe and effective. And I was saying to people, I don't understand how this could be communicated, because you have other vaccination options that don't have this risk. How is this still popular? How is this still a thing?
Yeah. So, okay. Yeah. I mean, safe and effective doesn't mean no adverse effects. You're absolutely correct. And maybe they're extraordinarily effective, but they're not 100%. I mean, we're seeing about a 94 to 96% reduction in severe disease, hospitalization, and death. There are some people who are very frail and vulnerable who will never have a good vaccine response. And some people frail and vulnerable who, I mean, unfortunately, it's that stage of their life where they're frail and vulnerable, vaccine or no vaccine. Are there some people who've had very, adverse? Yes, there are rare adverse effects, but they're not zero adverse effects. I would say that the overall benefit of the vaccination, particularly for adults, far outweighs the risk from what we've seen. So that sense, I'm not. I'm pro vaccine, but you're absolutely correct. One should not minimize the fact that there are individuals who have had some very significant adverse effects. Yes.
No, my point. I mean that's obviously
Yeah.
terrible in itself. But my point is the impression some of these people that aren't getting the vaccine, if you ask me, the group, the holdout group is, their perception is they have seen a bunch of communications from the government that have not panned out.
I see.
And so when they kept saying 2 weeks to flatten the curve, 2 weeks to flatten the curve, and that didn't happen, right? Their spidey sense went up. And when you got these things, I wasn't saying not to take the vaccine. I was saying I didn't understand how AstraZeneca could exist alongside this signal with another vaccine that didn't have the signal, and people not go, well, let's just put that AstraZeneca in the fridge for a month, see if this is real or not. But it was always this thing. Oh, the benefits outweigh the risk. So the problem is, I mean, there were a couple deaths, unfortunately. This is like a real serious thing, can't be minimized. And then that goes into people's heads. And it seems, I think, to a lot of people, like there's never an apology. There's never a moment where somebody is like, uh-oh, we made a mistake. We're going to adjust our protocols. We're going to adjust our system. We're going to change the way we do things so this doesn't happen again. The message is like, well, sorry for your loss. Everything worked perfectly, and we're trucking. And when people receive that message, they go, there's some kind of agenda out there which isn't benefiting me. I don't know if they can really see it or see the parameters of it, right? But when people come and say, are not very, very clear, okay, the benefits, the cost benefit analysis is to you personally, which it is for the old people clearly, which I've said from the freaking beginning that anybody asked, right? But then once you get down, there's this weird crossover point where the benefits are to some globalized society, right? And there might be a harm to you. Even being in the hospital for a week is no fun. You can get lots of things in the hospital that you now caught in the hospital. Story old as time, right? I'm sure you know this, right? So the problem is it crosses this line where it's like, is the risk benefit to me, or is the benefit to some global apparatus of public health? But there's a risk to me. And by the public health people not being crystal clear and hammering this out and providing statistics, they provide, I think, this impression in people that they're really attached to some kind of narrative, right? And they're unwilling to let it go. And that person just goes, I'm out. I can't believe anything. Maybe they sit through, an hour and a half podcast and they see what's being said and they get some confidence back. You know what I mean? Because the hospitals, like I took it because I'm like, the hospital's also not filled with people who are victims of the vaccine. Like you'd see that real quick, right? Which is why I took it. I'm like, well, you know what? Even if there's some weirdo potential side effect, the hospital's not filled with not filled with massive. They would have to be. Every place would have to be a disaster, right? If you had this ratio of vaccine problems that was all that high. But I think that's the class of the person you're not going to crack. And every time you come and put one of these, we're going to have a lottery. We're going to pressure you that your kids are going to be excluded for 20 days if they didn't get vaccinated, right? These people just go, the more pressure on me to do this, the more I'm sure it's not in my advantage. And so I think there's I don't know, I can't say what percentage that is, but I think there's a small a number of people you're never going to crack because of the rebound of the message.
Yeah, and that's probably okay, to be honest, because what our objective as a society, and again, this sort of requires taking that step back and going, whoa, okay, that's before we stress about who is or isn't being vaccinated. What are we trying to achieve as a society? And if we recognize that COVID is here to stay, but what we're trying to achieve is a dramatic reduction in hospitalizations, in severe disease, and in deaths, knowing it won't be zero, then that is what we've accomplished. That has flattened the curve. And while I would like people to protect themselves, we don't actually discriminate against people who do other things that maybe aren't in their best interest for their health. After all, we we provide care, and so I personally am happier with the public health messaging that is much more about harm reduction, risk mitigation, that's inclusive. I'm not personally, I'm not a fan of public health that ends up being coercive or punitive or exclusionary. Those have never been effective public health measures, and they're not going to be effective public health measures now. Naming and shaming and finger pointing and blaming, those are not effective public health measures either. And I would hope that we're better than that. So I'm, again, thinking, what are we trying to achieve as a society? What we're trying to achieve is this ability to coexist with COVID so that we don't see a lot of severe disease. We don't see a lot of deaths, knowing it'll never be, there will always be some. It's never going to be zero, as is true of pretty much every other infectious disease going, because these things do still circulate. But for the people who have elected to be vaccinated, they have dramatically reduced that. That person's individual risk is now dramatically reduced of any bad outcome. And I think that's okay. There's a point where you have to sort of decide what you're trying to achieve as a society. And I personally am not very comfortable with coercion. But again, we're all different, I suppose, in what we're willing to accept.
Well, and that you just hit the point on it, because the question I ask people now is, I say, now that you've gotten double vaccinated, right? And are you now willing to get COVID? Are you now willing to accept that there's risk in it? And unfortunately, I'm going to tell you, the people that I talk to that were in love with this at the start still say no.
Yeah.
And they'll insert something because of long COVID. There's this person in the hospital, and they've had. So that's the exciting thing, convincing them. But thanks very much, Martha. You've been very gracious with your time, and hopefully you got it all out instead of like a really compressed TV spot.
Yeah, I think it's to try to get these sort of all the shades of gray and the sort of the pros and cons. It's not an easy conversation. It's the risk tolerance level is hard, but I think we've done a lot of harm to our society. I think there's a lot of mental health harm even in adults. The people who are vaccinated who are still scared to go out, still scared to take a mask off, that's actually a lot of harm to those people as well. That's a lot of fear, a lot of anxiety that I don't know. I think we've got a lot of healing to do going forward.
Excellent. Well, thanks very much.
Thanks.